Okay. Thank you very much. The other time we're getting interruptions. I hope everyone is muted. Yeah, that's good. So today we are going to look at the congenital anomalies of the upper urinary tract. And the network disturbed us when we had just started, actually. So I was saying that the introduction, in the introduction, we are saying the normal renal development is dependent on the interaction between the ureteric bud and the metanephric mesenchyme. And we are saying that these two help each other, that if one does not develop, the other also doesn't develop. And we shall see how important that is later on. And this induces organogenesis, resulting in the formation of the nephrons and the collecting system in each kidney. Of course, it will be important for you to go through the embryology, but it's something I want us to watch briefly, and then we shall continue. So I'm going to stop sharing the screen, then I'll come again. Are you guys following? Pardon?
We are not sharing.
From my side, there's no voice.
There's no voice, but you can see the video.
Yes, you can see the video.
But there's no voice.
No, there's no voice.
How about the rest?
That's it.
It's the
No voice.
No,
There's no
actually,
voice.
the voice is there, but it just keeps stopping. I think it's a network issue.
Ah, okay.
Just some cell clusters and tubules and the pronephric duct. This duct opens into the chlorople, part of which is the bladder. But for now, it's still the chlorople. It degenerates. So we're just going to. This appears late in the fourth week. They have mesonephric tubules, which are like permanent versions of male tubules. These are associated with Some of these can be done as well. Okay, so this is going to form the actual. So let's function this way. This is the ureteric bud. Now this is going to form the collecting system of the kidney. The lower part of the nephrogenic cord has the metanephric blastema. The ureteric bud induces in turn induces the ureteric bud. So the ureteric bud forms the calyces, the renal pelvis, and the ureter, so everything from the collecting duct downwards. And the metanephric blastema forms the excretory portion from the glomerulus to the distal ureteric. As gestation continues, the number of nephrons increases, because ultimately the kidneys have millions of nephrons. But the kidneys ultimately have to be in the abdomen. That's what so initially that message was inches of the whole renal pathway the kidneys function glomerular. That drains into the cloaca and then into the amnion. That is how the kidneys develop. 3 stages. Granulocytes,
Okay, I think we shall just proceed. The video seemed not to have been the best, but you can always check those things on YouTube. You can read, just have, makes life very easy. You can follow the lectures very easily. So the most important thing in development of the kidney is just the interaction of between the ureteric bud and the metanephric mesenchyme. So these are categorized, the congenital anomalies of the upper urinary tract. When we talk of the upper urinary tract, we are talking of the kidneys and the ureters. Of course, the calyces and the pelvis and the ureter. So we are going to look at these congenital anomalies in terms of number, ascent, form and fusion, rotation, renal vasculature, and the collecting system. And these are in line with the kidney, the kidney and the ureters. So we shall start with the numbers. In the anomalies of the numbers, we can either have both kidneys not developing, or we may have just one kidney that has failed to develop and the other side is okay. So we have the bilateral renal agenesis and the unilateral renal agenesis. Of course, bilateral renal agenesis is not compatible with life. And so these people will usually, the babies will be born dead. And these ones are due to failure of the development of the mesonephric duct. Remember in the video, or even in the introduction, we said the development of the kidney and the ureter is dependent on the interaction between the ureteric bud, which develops on the mesonephric duct, and the metanephric mesenchyme. And so we said that failure of development of one actually also affects the development of the other. And so we are saying in bilateral renal agenesis, there may be failure of development of the mesonephric duct, from which the ureteric bud develops. And also there may be failure of the ureteric bud to form. Now, this diagram that you see, let me just pick my... So this diagram you see, this is the mesonephric duct, okay? And this is the metanephric mesenchyme, this round, this oval thing. And we said that there must be an interaction between a ureteric bud and the metanephric mesenchyme. So the metanephric bud develops at this point. This bulge you see is the development is the ureteric bud. And so it must interact with the metanephric mesenchyme. These things we are seeing are the genes responsible for that interaction. And this BMP4 is responsible to make sure that the ureteric bud only develops in one place. It does not develop at different sites. So it makes sure that the ureteric bud develops at one place, so that at the end you have one unit. There's someone causing interruption. Please mute. Yes, so these are the genes that are responsible for that. And if, for example, this BMP4 is not is mutated, then you will have a possibility of ureteric buds happening at different sites. That you can have one here, you can have one there, you can have several. So its role is to ensure that it develops in one place. And then, of course, when the interaction with the metanephric mesenchyme happens, then the development into the nephrons and the collecting system happen, like we have already discussed. Let me just put back this and we continue. So that is the bilateral renal agenesis. It is associated with some syndromes, Kalman, Klinefelter's, Fraser, and cryptophthalmos. These children may also have esophageal atresia. Portaphyses are very common, but the most dangerous is the pulmonary hypoplasia, and that's the one. That's the one that causes death. Because these children are not producing any urine. So the biggest cause of death in these children is pulmonary hypoplasia. Now, in the diagnosis of the bilateral renal agenesis, of course, with the improved technology, people are able to do the prenatal ultrasonography, and you see oligohydramnios and no renal parenchyma. Postnatal ultrasound sonographies can also be done, of course, when the children, these babies are born. Now, in the unilateral renal agenesis, the embryology is not very different. It means that either the ureteric, the mesonephric duct did not develop. If it developed, then the ureteric bud did not develop, and therefore the interaction with the metanephric mesenchyme could not happen. So that is the embryology. And these congenital anomalies, the unilateral renal agenesis is associated with anomalies of the Wolffian duct and the Mullerian duct. When you go through your embryology, you'll understand these Wolffian and the Mullerian ducts. There can be also associated conditions of the cardiovascular, gastrointestinal system, and also the musculoskeletal. And in the diagnosis, still we can use the prenatal ultrasonography. Renal scans also are very important, and ureterovesical reflux. Vesicoureteral reflux is common because it is at 28%, and it is more common in the contralateral side. The parents are usually concerned about having one kidney, and these are usually those children whom you do ultrasonography for other problems, and then you discover that they have one kidney. But these parents should be reassured, because these patients usually live a normal life. And currently, some scholars are suggesting that these patients are predisposed to hypertension, proteinuria, and mild renal insufficiency. So the other anomaly is what we call the supernumerary kidneys. And these kidneys, you find that my internet keeps going off. I hope you're following.
Yes, doctor.
Yes, doctor, we are following.
Okay, that's very good. So in the supernumerary kidneys, instead of having one kidney, you actually have many kidneys. The first ones we have seen were that you may have no kidney in both sides. The other one was that you can have one kidney and the other one is missing. Now, the supernumerary now is the opposite. Instead of having one kidney, now you have more than one. And these are usually due to a second ureteric bud or branching of the ureteric bud. And then that is followed, which is followed by the division of the metanephric mesenchyme. In other words, if you have one ureteric bud and one metanephric mesenchyme, then you should end up with one ureter and one kidney. And so for you to have more than one kidney on one side, that means you had two things happening at the same time. You had a second ureteric bud arising and division of the metanephric mesenchyme, so that you have two ureters and two kidneys developing on one side. And usually both kidneys are normal, and these patients are usually asymptomatic. So if you discover it incidentally, there should not be any cause of alarm. You should reassure these patients. And this diagram just shows you how the several kidneys can look like. Now, there are also what we call the anomalies of ascent. I hoped that I would show you another video, but since the other one was not clear, I think you can always watch those things on your phones. But what is important is that the kidney actually it develops in the pelvis. And that kidney has to go through ascent. It has to leave the pelvis and ascend all the way up to the normal position that we know, the normal anatomical position of the kidney. Now, sometimes that ascent actually fails. So you find that instead of the kidney being in its normal position, you actually have the kidney, for example, in the pelvis. Okay, so you have the kidney at abnormal positions. So we can have simple renal ectopia. We can have cephalad. We can have thoracic. We can even have crossed or contralateral anomalies of ascent. And and this is what we've been talking about, that the mature kidney fails to reach its normal position in the renal fossa, and the different positions can be the pelvis. The kidney can fail to ascend at the iliac level, in the abdomen. Sometimes it may actually ascend and go past the normal renal fossa, and you find sometimes in the thorax. And of course, sometimes also it can be on the contralateral side, and that's what we call crossed. We shall see some pictures. Now, when these kidneys are ascending upwards, they actually go through a rotation, and that rotation ensures that at the end of the day, you have the normal orientation of the kidney, that you have a kidney that has the renal artery running from the aorta directly, laterally, just to attach the kidney. And we shall see later that initially the pelvis is actually looking anterior, because you know in the normal kidney, the pelvis actually faces medial, but initially the pelvis is facing anterior. When you're standing, just assume that the kidney is oriented and the pelvis is anterior. And then because of that rotation, then you finally have the normal orientation of the kidney. So the renal pelvis is located anteriorly, which is different from renal ptosis. Renal ptosis is should also be differentiated from an ectopic kidney, in that the renal ptosis, in renal ectopia, the kidney is permanently in a wrong position. Say if it is in the pelvis, then it is there permanently. In renal ptosis, if the patient somersaults or is upside down, if they put their hands up and put their legs up, then the kidney changes positions. So there are times you find the kidney in the normal position. There are times if the patient stands up, the kidney goes back to the pelvis. So that's the difference between the ptosis and the ectopia. So this diagram just shows you, let me just see a bit of the charts. Okay. So we shall reserve all the questions, and we shall ask them at the end. So in the simple renal ectopia, are we following? I think we are now okay. So in the simple ectopia, are you guys still following?
Yes, we are still following. We're still following.
Please, when you get some interruptions, don't shy away from letting me know. And those writing on the screen, please use the chat box. This is Joseph, the terrible fellow. So in the simple ectopia, we are just, in this diagram, you can see that the kidneys are in the normal positions. You can also see the kidney in the pelvis and the lumbar region. And that is how the simple ectopia is. And of course, we think that the ureteric bud maldevelopment may be one of them. Metanephric tissue defects some maternal factors, some teratogenic aspects, and vascular barriers. We shall look at the horseshoe kidney also, and we shall appreciate which artery actually causes the arrest of those kidneys. So the simple renal ectopia is associated with genital anomalies and ectopia. The adrenals almost always arise from totally asymptomatic.
Yes, doctor. Doctor, not hearing you. Not hearing
Can you
you.
hear me now?
Yes, I can hear you now, doctor.
Okay. So the simple ectopia may be associated with congenital anomaly position because they arise from a totally different tissues, and then most of them are symptomatic, of course. But usually, I like to warn people that sometimes you have several things happening at the same time. You may have a simple renal ectopia that is also associated with unilateral agenesis. It's not rare to see some cases in the outskirts, people just doing nephrectomy because of a pelvic mass, and what they have done is to remove the only kidney of the patient. Otherwise, these patients usually live a normal life, and these are mostly incidental findings. So this diagram shows of the cephalad and the thoracic kidneys. If you look at, this is an IVP, and you can see, just pick the pointer. You can see that this renal artery is, for example, going upwards there, and you can see that in this IVP, the kidney on the left is actually in the right position, but look, the one on the right actually is thoracic. So sometimes these cases also may happen. So there are also anomalies of form and fusion. And in these we can have crossed renal ectopia without fusion, then with fusion, and then horseshoe kidneys. So this diagram just shows you the crossed renal ectopia. And what we mean by crossed renal ectopia, we mean that the kidney is in an abnormal position, but it also crossed from its normal side and crossed to the other one. Like, for example, this one is crossed renal ectopia with fusion, and you can see that the kidney on the lower side, this one here, actually is the one that crossed, because its ureter attaches the bladder this side, and it just crossed to that side. It is very common that the kidney that crosses actually is the one that is lower. In other words, its upper pole attaches the lower pole of the upper kidney. Why? Because just imagine that the kidney that is normal and it ascends on its side does not lose time. The one that crosses, instead of going into a straight route, it loses time because it has to first negotiate that crossing. So the orientation is always that the kidney that crosses is oriented in is lower, is on the lower side, and attaching on the lower pole of the kidney in the upper side. Then you can also have without fusion. You can see these kidneys are fused. This is cross-renal ectopia without fusion. So this kidney this side crossed, but it is not fused with the one that is on the normal side. Okay, and then you can have a solitary crossed renal ectopia where there is renal agenesis. I think we had also talked about it briefly. So there is renal agenesis. Okay, on this side the kidney did not form. On this side where the kidney formed, it also crossed to occupy the renal bed on the opposite side. Then you can of course have the bilateral crossed renal ectopia, and you can see that the kidney on the right went to the left. The one on the right went to the left, and the left went to the right. And so you can have also that kind of cross ectopia. Let me first put this back. You can also have more varieties of cross-renal ectopia with fusion. You can see that this is what we've just talked about, the unilateral fused kidney with the inferior, what we call inferior ectopia. In other words, this kidney is on the lower side because we use the kidney that cross. So this is called inferior ectopia. This is the S-shaped or sigmoid. You can see how this is a lump. The kidney crossed, but it also found that the other one was anectopic. It was in the pelvis, so it didn't ascend. You can see this L-shaped. You can have different shapes. This is a disc. This crossed, but it fused medially. And then, of course, you can have unilateral fused with superior, which we said is rare. The one that crossed actually goes and is the one on top. This arrangement is very rare, the F. So the horseshoe kidney, this is the most common form of fusion. And it is it's said that 95% the fusion is at actually the inferior pole. It's what we are discussing. And the embryology is that alteration of the umbilical arteries or the common iliac arteries changes the orientation of the ascending kidney to cause fusion. And when the kidney is fused, when you have a horseshoe kidney, if there is fusion and the kidney tries to ascend, they are usually arrested by the inferior mesenteric artery because of the isthmus in between. It will be arrested by that artery. And the symptoms that these patients may present with are usually associated with, they are usually related to hydronephrosis, infection, and of course, stone formation within these kidneys. Otherwise, if these are not there, then these patients will live a normal life and you'll only find them as incidental things. Then we also have anomalies of rotation. Remember, we said that internet. Okay, I think we are still okay. So there are anomalies of rotation, and these ones arise from failure of rotation during ascent to the renal fossa. The renal pelvis varies in position from medial to some degree of malrotation. And so you can have the ventral position, you can have the ventromedial position, you can have the dorsal position, and you can also have the lateral position. And we are going to look at these positions. The best thing is to first assume, to first remember the normal orientation of the pelvis, that the pelvis is actually medial, okay? So when you look at this diagram, let me just keep this point, just try to make life easy. So initially, this is how the kidney is, okay? And consider this to be anterior. This side is anterior. In other words, this kidney is now facing, this pelvis is facing anterior, or you can say ventral, okay? And this is the initial orientation of the kidney. But when the kidney ascends, by the time it gets into its normal position, the kidney should be oriented as in B, because you will have the aorta here. We know that the aorta is here, and we know that the renal artery leaves the aorta to supply the kidney, and this is how the kidney is oriented, normal anatomy. But initially, this is what it is. So C is showing you that this rotation. So we're still talking about the rotations. So we're saying that sometimes the rotation happens a bit, but not to its normal position. In D, it demonstrates that the rotation actually happens and passes the normal orientation and even continues. And therefore, you find the pelvis actually facing dorsal. Okay. And then, of course, this one also over exaggerates that the rotation has gone beyond, and the pelvis now is facing laterally. Okay. And of course, this one also shows that instead of the rotation going this direction from this point, now it has gone to the other direction. So these are the different forms of the malrotation. And what is important is for you to know that initially the pelvis is facing anterior, and there is a rotation, that rotation, to make sure that the final position of the pelvis is medial. And then we have anomalies of the ureters. Let me just check on the chat box and see if it's. So we also have anomalies of the ureters, and among those anomalies, we can have the anomalies of ureteral duplication and ectopic ureter. Now, ureteric duplication means, remember, normally we have one kidney and one ureter, but this time we may have two ureters. So that's what we call ureteral duplication. We may also have ectopic ureter, that instead of the ureter, for example, attaching to the bladder, you have this ureter attaching to the vagina. If you have been on OBS-GYN, this is one thing that you must have met: ectopic ureters. Especially children that are about 8-10 years. These are children that keep wetting themselves, although they also have normal micturition. They feel the urine in the bladder, they go and urinate. But on top of that, they have a little urine that keeps leaking. And that is when you have ectopic ureters attaching to the vagina. It is the commonest site where the ectopic ureters attach. And so, because there is no sphincter mechanism there, the urine continues to leak, so they are incontinent. We can also have ureteropelvic junction obstruction. And we know that, we know that after the calyces, you have the pelvis and then the ureter. So the junction between the pelvis and the ureter also may get obstructed. And then we have something called the retrocaval ureter. This one only happens on the right. And if you remember the course of the ureter should not at any point cross posterior to the vena cava. But in this congenital anomaly, you have the ureter crossing behind the vena cava. And of course, that causes obstruction. This diagram shows you the ureteric duplication. And we can have complete duplication or incomplete duplication. Complete duplication means the upper pole and the lower poles of the kidney each has a ureter that goes and attaches to the bladder independently. And the incomplete one means that maybe the two ureters originate from the upper and lower poles of the kidneys and then fuse and attach to the bladder as one. And you'll meet this is that the ureter that drains the upper pole of the kidney is the one that usually gets pelvic junction obstruction. And we are saying that you can have stenosis, aberrant vessels, and a ganglionic segment. And this diagram, let me just put the pointer. So this diagram just shows you this is where the obstruction is. You can see the whole kidney. These are the calyces. This is the pelvis, and the obstruction is here. And you can see that there's this tension of the pelvis there. And this one shows you the aberrant vessels. You can see these ones are going anterior, but the lower artery is actually supplying the posterior aspect, and it is kinking the ureteropelvic junction there. This diagram shows you the retrocaval ureter. You remember we talked about it, and we said it only happens on the right. And you can see that this ureter, this pelvis is actually distended, and it comes, and you can follow and see that it actually comes out from there. So it goes behind the vena cava. And when you're managing, of course, you don't cut the vena cava. Rather, you resect you transect the ureter, and then you anastomose it in its normal position. You don't touch the vena cava unless you are looking for trouble. Then, of course, we have anomalies of the renal vasculature. We have aberrant vessels, accessory, and or multiple vessels. We may have also renal artery aneurysms, and we can also have renal arteriovenous fistulae. The collecting systems also have their congenital anomalies, and I would encourage that you read them up and try to see what all these look like. But you can have diverticular of the calyces, you can have hydrocalicosis, megacalicosis, you can have a unipapillary kidney, you can have kidneys that have calyces that are outside the kidney. You can also have a pelvis that is outside the kidney, or you can also have the bifid pelvis, that instead of someone presenting with one pelvis, they actually seem to have two, and those joined to form to continue with the ureter. Yeah, I think that is what we had on the congenital anomalies of the upper urinary tract. Our internet has not been the best, but my hope is that we try to follow through. I've been also trying to check on the chat boxes, and I see very nice discussions. I don't see any questions. So that's all we had for today. I will take about 3 questions because I need to run and start the clinic. You know how Friday clinic is on Friday. The urology clinic runs on Friday. So if there are any questions, you could just put up your hands. I'll only take 3, and that will be it. So if you can just raise your hands, I'll be able to answer some of the questions.
Bure, ask your question. Bure, please unmute and ask your question.
Godfrey, you can unmute, ask your question, please.
It's net. Doctor, it's network issue. However, it's not a question, just a follow-up that since we don't attend the renal clinics, it was my humble request that you forward us the clinical questions for discussion so that the clinical questions, renal questions that we may discuss and get updated because we are not attending the renal clinics. It's not a question, just a humble request. Thank you.
Okay, thank you. Thank you. This was good. Yeah, thank you very much. In line with the same, I asked your leader to make the WhatsApp groups, and then I'll keep sending everything we see in the clinic, like especially the images. We can always discuss on those groups. And I would encourage Padre to take it on. Yeah.
Doctor, there are some questions in the chat. If you mind them out, then maybe.
In the chat. In the chat, what does IVP stand for? This is. Okay. This is a good question. So IVP is intravenous pyrography, and Padre.
Yes, doctor.
I sent you the tutorials and the lectures. Yes.
Yes, I shared with them.
Now, yes. Now the tutorials. If you arrange and we can have an interaction, I have no problem. But if you fail, then you use the Smith. You read on by yourselves. The tutorials,
Okay,
especially,
doctor.
and the imaging investigations also follow the tutorials. So people should read those so that we are at par next time. But otherwise,
Okay,
the IVP is an imaging investigation where a contrast is given intravenously and pictures are taken. And when they are taken, you can see the whole kidney, you can see the pelvis, the ureters, the calyces, the outline basically. So it's just an imaging modality. Then I see someone had a question about the let me see, about the retrocavo ureter. The retrocavo ureter, being an abnormal cause, it will cause obstruction. And of course, when there's obstruction, you are concerned. Otherwise, you'll have, you may end up with permanent kidney injury. I think those are the only ones I have seen.
Yeah, yes, doctor.
Yes, unless there are other issues.
There was
think
one. There's
Mm.
one from Edison. What's the connection between the collecting duct and the Wolffian duct biologically?
The collecting duct.
And the Wolffian duct.
No, now the most important thing is the mesonephric duct.
Yes.
And the ureteric bud is the one that gives the collecting system. Okay, it gives the ureter and the collecting ducts. You know the nephron very well. We have the collecting duct, we have the distal convoluted tubule, we have the loop of Henle and the proximal and blah blah blah. Eh? So yes, the ureteric bud gives the ureter and also gives the collecting ducts. The mesonephric duct is the one that contributes the nephrons, except the collecting duct of the nephrons. I hope we are good. Eh?
Yes, doctor.
Okay. So I think, thank you very much. Today, the session, I want to believe was interesting, except for the internet interruptions. And we are going to keep working to improve, especially the connections, because the other time I think it was better than today. Otherwise, we shall follow the schedule that I sent you. I didn't think it would make sense putting dates and the names of those who will be giving the lectures since I'm alone. But the way the lectures are written is how we shall be moving in terms of tackling them. So I would encourage you to read the next topic, so that when we're having the lectures, you follow very easily. So have a nice day, and I wish you a nice weekend.
Thank you, doctor. Have a nice